In this lecture, we will look at primary prevention of cardiovascular events in patients with moderate to high risk of developing cardiovascular disease. We will also discuss rehabilitation or patients with documented cardiovascular disease in the acute care, post-acute phase, and in-home-based rehabilitation. Therapeutic interventions, including cardiac rehabilitation, might not be necessary for many individuals if primary prevention is employed. Primary prevention is defined as active intervention for risk factors that cause cardiovascular disease. Major risk factors are cigarette smoking, hypertension, obesity, hyperlipidemia or hypercholesterolemia, low physical activity, and diabetes. The American Heart Association guidelines include assessment for cardiovascular risk beginning at age 20 and repeated every few years or more often for those at increased risk. The two major problems in primary prevention are compliance, especially in the long term, and lack of payment for primary prevention education by insurance companies. Primary prevention may help with high cholesterol, weight control, and exercise tolerance, and increased capacity, reduction in blood pressure and glucose levels, improve well-being and stress tolerance. The primary components of a primary prevention program include therapeutic exercise, dietary counseling, stress management and biofeedback, smoking cessation, pharmacological management, and education on self-management techniques. Specific goals of primary prevention include reducing blood pressure below 140/90 millimeters of mercury for uncomplicated hypertension, below 130/85 for patients that have renal insufficiency or heart failure, and below 130/80 for diabetics. Goals for physical activity include 30 minutes of moderate intensity exercise most days of the week, flexibility exercise and resistance training, reduction in LDL below 160 milligrams per deciliter and less than 100 milligrams per deciliter if more than two risks are present or patient has diabetes, identifying stressors and encouraging group support or professional counseling, reducing body mass index to 18.5 to 24.9 kilograms per meter squared, diabetes control with fasting glucose less than 110 milligrams per deciliter, complete smoking cessation and limiting secondhand exposure, promoting healthy eating and limiting saturated fats, cholesterol, and alcohol consumption. Primary prevention should be implemented at the worksite, fitness center, senior citizen center, primary physician office, outpatient clinic, and cardiac rehabilitation center. Patient populations selected for rehabilitation include those that may have a primary cardiovascular disorder such as an acute coronary syndrome, myocardial infarction, coronary artery bypass graft surgery, heart or heart-lung transplant, heart valve repair or replacement surgery, congestive heart failure or secondary cardiovascular disorder such as a history of the diseases. Interventions will be based upon impairments identified in the initial examination. Review of the medical chart and the patient-family interview are critical. Rehabilitation should include education, exercise, and behavioral changes and be organized as progressive phases. Specifically, education of the patient and family should include recognition, prevention, and treatment of CVD, reduction or removal of risk factors, psychological intervention to help with recovery from heart disease, structured progressive physical activity, vocational or return to leisure activities counseling, and functional training to improve ADLs. This program may begin in the acute care setting with early mobilization of the coronary patient to reduce complications and improve mortality rates. Poor candidates for rehabilitation include overt CHF, unstable angina, hemodynamic instability, serious arrhythmias and conduction defects, and impaired organ systems, uncontrolled hypertension, and other conditions that prevent safe exercise. Initial assessment should be done when the patient is stable and similar to pulmonary rehab program evaluation, should include chart review, patient-family interviews, physical exam, evaluation of current self-care and ADLs, and ambulation activity. Patients who exhibit normal hemodynamic, ECG, and symptomatic response to ADLs and sitting, standing, and walking should be candidates for an unmodified program. Indications for a modified program are patients who have had a large infarction within the last 2 to 3 days, resting tachycardia, blood pressure not rising or decreasing during ADLs, ECGs revealing greater than 6 to 8 PVCs or progressive heart blocks, angina, and severe fatigue, or patients that have experienced complications post-MI. Patients that have severe pump failure as indicated by shortness of breath, peripheral edema, diaphoresis, or chest X-ray are in a high-risk category such as angina at rest, second or third degree heart block, recurrent malignant arrhythmias, persistent hypotension even with vasopressors, or rapid atrial rhythms in the last 24 hours should be withheld from any rehab program until stable. The patients just described as those in which therapy should be withheld are considered complicated MI patients per the McNeer criteria. Once the patient has begun rehabilitation, they must be reassessed each session and relative contraindications noted and exercise discontinued. Any symptoms such as angina, excessive dyspnea, fatigue, mental confusion, dizziness, etc., and ECG abnormalities should also be considered when continuing therapy. Any instructions such as dietary considerations, prognosis of the disease, what to do in an emergency if chest pain recurs, medications, sexual concerns, etc., should be simple, told to both patient and family, and organized in a packet. Audiovisual aids, such as booklets and videos, are also helpful. Other components of acute care rehabilitation include diet and nutrition provided by a dietitian, and psychological and behavioral rehabilitation to reduce fear, anxiety, depression, and/or anger. Appropriate clinicians should be involved in this process. Discharge planning may include referral to an outpatient rehabilitation, and outcome measures may be limited in the acute care setting, but may include self-management of symptoms, patient understanding of risk factors associated with their condition, improved aerobic or endurance capacity, ability to perform self-care, symptom management or improved safety and reduced supervision with activities or tasks. Post-acute phase cardiac rehabilitation is defined by Medicare and Medicaid services and the National Coverage Determination, NCD, as a comprehensive long-term program involving medical evaluation, prescribed exercise, cardiac risk factor modification, education, and counseling. The NCD 20-10 provides coverage guidelines as MI within the past 12 months, CABG, stable angina, PTCA, heart or lung transplant, and valve repair. Other candidates for cardiac rehabilitation include heart failure and angioplasty. Candidates for home-based cardiac rehab include patients with heart disease who had an uncomplicated hospital course and are considered candidates for cardiac rehab, but are unable to travel to the program.